Hello and welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is May 25, 2021. This episode was recorded on May 5, 2021. I'm Jeff Lassers and I'll be your host. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. In today's episode, we discuss Tranexamic Acid, or TXA. TXA is a medication that helps the body from prematurely breaking down clots. It doesn't make new clots. It protects existing clots as they are formed. TXA was originally developed for the treatment of hemophilia and to reduce bleeding in patients undergoing oral surgery. Eventually, it was shown to be an effective preoperative drug that minimizes the need for large amounts of whole blood during general surgery procedures. TXA is now being used by EMS to treat severely injured trauma patients in the field who have or are at risk for severe hemorrhage. Specifically, starting June 2021, TXA will be added to the drug box in my rig, along with every other EMS rig in Michigan's Southeast region, which includes over a half dozen counties in the area. This new addition to the box will affect thousands of EMS units, paramedics, and hundreds of EMS agencies. If you are a paramedic in my area, I suggest you reach out to your EMS coordinator and find out if this change will impact your treatments. See the Southeast Michigan Medication Exchange and Replacement Procedure, the Shock Protocol, and in the Medication section under Tranexamic Acid for additional details. You can download these protocols at ocmca.org/protocols or at the OCMCA EMS Protocols app, which you can download for free at the Google Play Store or at the Apple App Store. I've never used TXA in the field. I've really only read about it and its effects on EMS trauma patients with severe blood loss. So to assist us in the discussion, we've invited our good old buddy, Dr. Steve McGraw, back to the show. Dr. McGraw is an ED physician at Ascension Providence Hospitals in both Southfield and Novi, Michigan, as well as the EMS Medical Director of the Oakland County Medical Control Authority, which provides oversight to over 50 EMS agencies. We also welcome back John Thoit, who is the Quality Assurance Quality Improvement Coordinator for the Oakland County Medical Control Authority right here in Southeast Michigan. John is also a soon-to-be retired shift captain and the EMS coordinator for the Ferndale Fire Department. Finally, we welcome our MCA neighbor, Luke Bowen, as a first-time guest to the show. Luke is the operations manager for the Macomb County Medical Control Authority, which is one county east of Oakland County, Michigan. Oakland and Macomb MCAs have a history of collaborating to develop education and EMS improvement strategies, and we are happy to have Luke here today to represent his neck of the woods. In today's episode, our guests help us describe what TXA is and what it does. Then, they will list and describe the indications and contra-indications. After that, we'll get into the dose, route, and method of delivery for TXA. And finally, our guests will list and describe adverse reactions and side effects that may be witnessed by EMS after the administration of TXA. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com. Thank you for listening to the EMS On Air podcast. Enjoy the episode. Good morning, everyone. How are we doing?
Doing well.
Doing great.
Very good. How are you?
Fantastic. Well, let's get rolling today here. We have two new guests. Actually, one guest that's brand new. One guy's been here before. Let's start with the new guy, Luke Bowen. Can you introduce yourself to our audience of who you are, what you do, and where you do it?
Sure. My name is Luke Bowen. My current role is that of the operations manager for the Macomb County EMS Medical Control Authority. I am a paramedic. I'm an IC. I am currently teaching at Macomb Community College, entering my 35th year of EMS coming up this fall.
We appreciate it. So you kind of do what John and I do in Oakland County, and you're our neighbor. And John, why don't you go ahead and reintroduce yourself to our audience?
Hi, I'm John Thoit. I am the QA/QI coordinator for Oakland County Medical Control Authority. I'm also a shift captain and EMS coordinator for Ferndale Fire Department. Been there for 25 years. And soon to be not there very, very soon.
John is lucky enough to make it all the way through a full retirement here. He's got about another week to make it. So hopefully John gets through this as smiling as he is right now. And nobody can see it, but we can. Okay. So Dr. McGraw, welcome back to the show. You're always here. Everybody knows who you are. He's the Dr. McGraw. Can you start us off with talking about what TXA is? Give everybody an identification of what this medication is to kind of kick off our discussion.
Thank you, Jeff. First of all, I want everyone to understand, while it may be new to us, TXA, Tranexamic Acid, is actually not a new medication. It's been around for many years. It's actually a product of a company that we're all becoming familiar with, Pfizer. It is brand named Lyseta, and what it does is it acts as a lysine analog. Lysine is a very common amino acid. It's in a lot of enzymatic processes that we have in our body, and it's an essential part of the clotting cascade that makes all of our blood clots that occur in our bodies work. You guys, I'm sure, remember, we've talked about this in the past, that the clotting is a delicate balance between clotting, actively the cascade of things coming from platelets that allow a clot to form, and a simultaneous unclotting or fibrinolysis effect. Because we have to have that delicate balance to be both fast, because clotting has to be fast and effective when it's required, but also controlled so that we don't clot big things in big blood vessels and cause things like strokes and heart attacks. So it's this very fine-tuned balance. And you guys will remember that we give people TPA in the case of stroke, or used to give it in the case of STEMI, because tissue plasminogen activator kind of accelerated, if you will, the rate at which clot is broken down. It's breaking down anyway. If we activate plasminogen, we actually cause it to break down faster. This is kind of like that, only the opposite way. The lysine analog, that is TXA, causes a decreased rate at which plasminogen is turned into plasmin. And what does that do? It slows down that fibrinolysis effect. If you think about it, it's kind of like gently stepping on the brake of fibrinolysis, which tips the balance a little bit more towards clot formation. And I guess reason that's so important, if you think about it, all we're trying to do is take that delicate balance and tip it in one direction in the case of TXA, so that the clots that are forming are broken down less quickly. And that's effective too, because you can imagine that if we're experiencing a life-threatening bleed from polytrauma, or in the case of hemophilia, for which the drug was originally developed, there is widespread potential for bleeding. And what this really does is make whatever clot is being formed a little more capable of becoming a mature clot and not broken down by plasmin, because we decrease the rate at which plasmin is derived from plasminogen. What we're really talking about is just tipping the scale, if you will, just a little bit towards the proclot side and away from the fibrinolysis or the clot breakdown side. And all it takes is tipping that scale just a little bit, but have a large impact on someone who is experiencing a life-threatening bleed.
Thank you, sir. Luke, can you kind of give everybody listening an opportunity to understand when they would use this, the indications for TXA?
Sure. The indications are, as Dr. McGraw spoke about, significant hemorrhage. It's an exciting drug to bring to EMS. When we look at causes of death from traumatic injury, hemorrhage is only second to loss of airway. So these are patients that are high on that list of potential fatality for trauma. So we indicate the use for TXA with marked blood loss with an initial systolic BP of less than 90. What we do want to do is be clear and indicate that we are not using this for obstetrical bleeding or for internal gastrointestinal bleeding. So this is either internal or external hemorrhage from a traumatic origin.
So to paint the picture of these patients, we're talking about somebody who took quite a bit of trauma, maybe multi-system trauma with obvious bleeding, and we recognize that the potential volume loss of the blood is life-threatening, and we want to slow that down with TXA. Would you say that's a good summary of what we're using it for?
It is, and that bleeding can be external or internal. So if you have somebody who's had trauma that has an acute abdomen, so their abdomen is rigid and distended, and they have low blood pressure, and they have all the other signs of shock, that would be an indication, absolutely. So obviously external blood loss that we're having a difficult time controlling with the traditional, hemorrhage control methods of direct pressure and tourniquets, those kinds of things.
I'm so glad you said that, Luke, because we all think of bleeding like a gunshot wound or a severed extremity or something like that. But as you point out, there can be intra-abdominal or intrapelvic during pelvic fractures, enormous loss of blood, even a fractured femur. An isolated fall off a roof and an angulated femur, you can put several units of blood, as bones bleed enormously when they break, inside somebody's thigh. We've all seen it. It's that thigh that's really taut. They're in a lot of pain. Put them in the hair splint and stretch their leg out. Now, things seem like they're getting a little bit better. That's another example where there's significant volume, significant blood loss from a traumatic event. That would be a consideration for this particular medication.
It's interesting you mentioned pelvic fractures. When I ask my students, how much blood volume will your pelvic girdle hold? And they don't have an answer, my response is all of it. So you're right, potential for life-threatening hemorrhage.
I love that, Luke. Yeah, be open-minded to it. The other reason why I want people to be open-minded, and now we're going to talk about this, but people think, well, aren't we going to precipitate blood clots? And I want to point out that that's not how this works. This medication doesn't make you make a bunch of unnecessary clot. It kind of slows down the physiologic function of declotting that occurs anytime a clot is formed. That's the fibrinolysis, the slow breakdown of clot. It just slows that down by making plasmin less likely to be formed by plasminogen. It's a gentle application of the brakes. And there really isn't a downside to this. I've had conversations with people that would say, well, what if I give this and the person turns out not to have been bleeding? You haven't done them any damage. You're not going to suddenly develop a bunch of DVTs and pulmonary emboli. That's not how this works. So it's an extremely safe drug from that respect and really has upside as long as it's given early for people that need it the most.
Is there any type of hemorrhagic shock that we should not give this for? Can we do this for a patient that's having gynecological bleeding or gastrointestinal?
It's not indicated in our protocols for GI, gastrointestinal, or gynecologic bleeding, like postpartum bleeding. But having said that, it doesn't mean that they wouldn't be expecting that or even at least having it considered for them in the hospital. There's some caveats to its benefit and how it can be used in some of those situations. So really, in both of those cases, the first response would simply be crystalloid infusion followed by packed cells, and let the different elements of either of those environments be decided on at the hospital if they would benefit from TXA. This has been widely studied in EMS literature, and we know it does have an effect for traumatic hemorrhage. So pretty much anyone in that boat, I would certainly consider it for.
So Luke, how do I give this medication? How is it packaged? What are we doing? Are we snorting this thing like a Narcan? Are we just showing it to them and it magically going in? IM, IO? What are we doing with this thing?
So this drug will be given by paramedics. It's going to be carried in the Southeast Michigan Regional EMS drug box. So this is not a separate supply. It's going to be carried in our drug box beginning on or about June 1st. It's supplied in vials of 1,000 milligrams or 1 gram. We've recently modified the drug box content. So we used to have a 50 ml bag of normal saline. We've swapped that out for a 100 ml bag of normal saline. So the paramedic draws up the 1 gram of TXA, places it into the 100 ml bag of normal saline, and infuses it through their IV over 10 minutes. So it is really kind of a straightforward process. There's no reconstitution. It's just simply draw out of the vial into the 100 cc bag, infuse for 10 minutes.
And this isn't a weight-based thing, an age-based thing. Any restrictions in that regard, or is it basically the same drug, same dose, same application every time?
Absolutely, as you stated, same drug, same dose every time, 1 gram over 10 minutes IV infusion.
What should I expect to see change, if anything, in my patient? So every time I do a treatment, I'm always looking at this patient and constantly monitoring them for changes or not changes and noting that. What should I expect to see that I want to see happen?
I'll comment briefly on the Dr. McGraw ad, but this patient is in shock, and it's taken them a while to get there with their hemorrhage. While this is going to slow the hemorrhage, it's not like correcting anaphylaxis where you're going to see an immediate improvement. The worsening of their shock is going to slow down. And maybe if you have a long transport time, 30 minutes, 45 minutes, 60 minutes, maybe you see their blood pressure stop falling, maybe even stabilize a bit. But know that its impacts are long lasting and are going to benefit this patient over the next 1, 2, and 3 hours. So don't expect their blood pressure to rebound to 110/70. We're just not going to see that. It's going to take a long time for them to compensate for that blood loss, but we really are having longer term impacts by slowing that hemorrhage.
That's a really good point, Luke. It isn't going to be a dramatic, sudden change. And I think your example where you can say an EpiPen and anaphylaxis is much more rewarding, candidly, to see that happen. But that's not what this is going to look like. And if you're going to have a longer transport time, as you suggest, you might see a slowing down of their progression into shock. But it's still very worth giving. Every study that looks at when it can be given, the only conclusion they say is, if you don't give it within the first 24 hours, it doesn't really help. But most important, the earlier you give it, the more impact it does have. So 1 hour is better than 2 hours. 2 hours are better than 3 hours. And it clearly shows that the sooner you start it, that initial infusion, the greater chance you have of making a difference. The longer you wait and the longer it's delayed, it has less likelihood of impacting the patient.
Those comments lead very nicely into the precautions. And one of those is, as EMS providers in the field, we would like to deliver this within 3 hours of the injury. So if we have a patient, kind of like a stroke patient, where we don't know their last normal, or we don't know when their traumatic injury was or the start of their hemorrhage was, and it could have been 12 hours ago, then we want to be cautious and not use this drug. We need to know, and that probably accounts for the majority of our trauma victims. We know when their traumatic injury was. So that's really not going to inhibit us too much. But you also mentioned that it's pretty quick to get started, but we don't want to delay transport. Getting this patient to the trauma center is absolutely still crucial. So this is not something where we stand on scene if our ambulance is available and the patient is available to be transported. We don't stand on scene and administer this drug. Get them in the ambulance and get them moving, get them toward the trauma center, and then get this drug infusing. So we don't want to delay transport. And those are some of the precautions that are listed directly in the protocol.
And IV, but also IO, I assume, is still an acceptable route?
Yes, it is.
Okay. And now, obviously, you're saying that in these short transports, like I work for an agency, we have very short transport times. Even when we bypass, let's say, a level 3 or 4 trauma hospital for level 1 or 2, I'm still only going 15, maybe 20 minutes. So I have a very short time to my very good destinations. So I'm not going to see much of a change, but what I might see is reactions to the medication. Now, every medication might cause an allergy or an anaphylaxis, and I know what to look for with that. And I'm assuming the first step is stop the medication. But what other adverse reactions or side effects might I expect or might I see other than the obvious anaphylaxis or allergy to the medication?
You know, it's funny, Jeff, we actually don't typically see anything that looks truly like anaphylaxis from this. It's so much of an analog, or it looks so much to the body like lysine, which is in, every one of our cells. There's not a significant chance that you're going to have true anaphylaxis. What you sometimes see is almost a hypersensitivity reaction. There's even a particular kind of dermatitis. It's benign and it fades, but the skin can have sort of a blotchy red rash. I think the other thing, if it's infused more than over 10 minutes, if it's more quickly infused than that, say over a minute or two, there are times when it will cause almost like a histamine response where people won't have anaphylaxis with all of its attendant problems in airway, but it can make them feel a little goofy. It's described as giddiness or dizzy. And they may even have some transient hypotension, which is going to ameliorate itself with time and with IV fluid. Presumably in a patient receiving this infusion, you will take the full 10 minutes because it's going to make this much less likely to occur. And if it has any occurrence at all, it'll be even more mild. That's really why the 10-minute infusion side of it, 100 cc's infused, 10 cc's over the next 10 minutes per minute, you'll avoid any of the typical things that might make you uncomfortable, like the giddiness they describe. The rash can still occur, but it'll be very mild and limited. The other side effect, if there is one, is that if it's given quickly, or even if it's given over a normal 10 minutes, some patients do feel somewhat nauseated. They may even vomit or tell you it made them feel funny, meaning that, maybe a dizziness or a giddiness sensation, but it'll be transient and it would be easily offset by a dose of IV Zofran. But again, if it sounds like I'm suggesting there are very few meaningful adverse reactions, that's because there really are. This is a very well-tolerated medication if administered under the appropriate guidelines for the appropriate reasons.
I think one of the takeaways there is that it's easy to administer it too quickly, but it's not dangerous to administer it a little bit more slowly. These are traumatic patients who are critically injured. They're really sick. And these scenes are somewhat charged, and we all understand that. We've all been there. You'd be better off to start it off a little bit slow, kind of gauge what it's infusing at. Again, it's about 10 mLs per minute. And then if it's going a little bit slow, that's fine. But if you realize, wow, I've given 30 mLs in 20 seconds, you want to back that down. So it's better off to give it over a little bit longer than 10 minutes than dump it in 2 or 3 minutes. So just keep an eye on it. It can be eyeballed. You do not need an IV infusion pump for this. You can absolutely pull out your watch, count the drips, look at the bag, and infuse this safely. But a little longer is better than really quickly.
Glad you said that, Luke, because there isn't a penalty if it takes you 15 minutes. I want to point out, too, by you guys giving this as the patient is arriving, remember we said the sooner you start the clock on this, the better off the patient will be. And some studies have shown patients that would have wound up in the ICU for a lot longer when they got TXA either were in the hospital in the ICU for a shorter period of time or avoided ICU care in some cases entirely. There's a real advantage. Remember also that while you give the first gram, they're going to receive additional doses of medication over the next 16 to 24 hours in the hospital. What you've really done is started that effective, meaningful treatment upstream when they hadn't lost as much blood as they might otherwise. And that's really going to help not only what the patient ultimately experiences, but in fact, help the hospital. You'll save their administration of blood products. They'll have shorter length of time when they're in the ICU or in the hospital overall, which means they have a less of a likelihood to get hospital-acquired infections or fall and get injured in a hospital, or all the things that can happen when we're in a tertiary care facility. So you're really going to manifest all of that benefit by starting the infusion as early as you can and doing it exactly as you described, Luke. Err on the side of taking at least or more than 10 minutes. No one's going to criticize you for taking 15. And even if it did go in a little bit quick, remember the side effects are going to be ameliorated by slowing down or stopping the medicine and giving IV fluid or Zofran for nausea. It's all achievable. And if you needed to, you could always get online medical direction and say, we gave the patient this and they started having this rash. Should we stop the infusion? Should we continue with it? Should we just monitor it? You could always ask that question because in the end, your ability to even offer this to the patient is a net benefit. It's like extra credit.
I would also add that, these are really sick patients, and even arriving at a trauma center, there aren't 25 staff members all waiting around with a single task to do for this trauma patient. There's a lot to get done very quickly. And if we can check a box for them and get this infusing, that's one less thing that has to be done within the first minutes of arrival. So again, we're starting that clock sooner, and 10 or 15 minutes really does matter.
Yeah, time is tissue. I don't think this is any different, right? So to add to that, this is a medication that's being utilized throughout the nation and really throughout the world in a pre-hospital setting. It's not new, but it is new to our area. Luke, you talked about the Southeast Michigan drug box. This medication is going to go in there. What geographic locations will have this?
The Southeast Michigan Regional Drug Box covers from St. Clair County all the way out through Washington, Livingston County, cut down to Monroe, and then back up the river. So it's either 10 or 11 MCAs. The drug is being placed into the drug box for that entire area, but each MCA has to adopt the protocol, and virtually all of them are. And you will know that because you will receive education and you'll receive information that you are indeed starting this on June 1st. There are 1 or 2 MCAs that at the moment are not adopting it, and they simply will not use the drug. We've done that in the past where a drug has been in the drug box, but is not allowed to be used by certain MCAs. So we've done it before. The state's fine with that. But know that if it's in your MCA, you will have been notified well in advance. Let me add one more little detail there. We're doing this as a rolling implementation. So on June 1st, when a drug box is exchanged at a hospital and restocked, they will add TXA. We're not going to recall all the boxes and put TXA in the boxes on June 1st. There are drug boxes that sit for even weeks at a time in a backup unit, or it's an agency that doesn't utilize drug boxes very often. So it could be a week or 2 weeks. We are going to ask agencies maybe at the 2-week mark to look at your drug boxes. And if it hasn't been refilled since June 1st, put it in rotation, get it on a truck, get it used, and get it into the hospital to get the TXA in that drug box.
So, Luke, is the thought that hopefully by July, all the drug boxes would have this in it in circulation, and that could be expected that when you open one, you'd find it? Is that the hope?
That is the hope. We are not doing any kind of special stickering or labeling of the boxes. So in theory, and it's a theory, if the box was filled on or after June 1st, it should have TXA. Hospitals have to check a whole bunch of drugs in that drug box. It is possible, and we're not going to be too upset about it, if a box was exchanged, let's say on June 3rd, and they just simply didn't drop the TXA in. Being a new drug like this, though, as important as it is to have, we haven't had it until now. So if it's there, fantastic, use it. If it's not, it would be nice to notify the hospital when you exchange that drug box, or however, maybe notify your MCA. I had a box, it was exchanged on June 10th. There was no TXA. Let your MCAs follow up a little bit and see what's happening with that. But yeah, we would love to have it kind of by July 1st, all of them cycled through. And we'll work with the agencies, again, who may have boxes not exchanged very often to get them into rotation.
Very good. Any closing thoughts?
I just want to reassure our providers that we have the same kind of education we're going to be rolling out amongst the hospitals. As typical as it can possibly be, we'll do a good job in making sure nurses and physicians know that this is coming online in the MCAs where it does. but also recognize that not everybody works full time, and you may inadvertently come across someone who's unfamiliar with it. That'll be the chance for the provider to say, well, this is a new protocol we're following for traumatically injured patients in Oakland County. And, we followed our protocol and administered 1,000 milligrams of TXA to this patient, because we know that if it's given especially within the first hour, it has significant impact on morbidity and mortality for the traumatically injured. Give you a chance to help educate somebody that maybe isn't quite up to speed as we all learn to do something different. Whenever something is brand new to EMS, remember, it's also new to the hospital in that sense too. Every hospital has tranexamic acid and has been using it in various situations, but having providers do it, it bodes very well for the future. And it means that our MCAs in our Southeast Michigan region are embracing the technology in a way to help our patients. All we have to do is help the hospitals figure that out sometimes too.
My closing comments would be that this discussion has occurred in what's called the RTAC, the Regional Trauma Advisory Committees. So within the MCAs in our area and our regions that are covered by the drug box, the trauma programs, the trauma surgeons have been made aware. We ask for their support for this. So most of them, will never say all, have at least heard that, hey, TXA is coming to the field in Southeast Michigan sometime this year. So it's not going to be foreign news to them that TXA is out there. So we did engage the trauma surgeons as well as the emergency departments in this discussion. Looking forward to seeing its use, seeing its efficacy. We will be looking at every use of TXA. So each medical control authority will be looking at each use of TXA, going to be really easy to query by just looking at the medications given list. And we will do a little bit of work to see, were there any adverse reactions, side effects, and we might even go as far as looking at the patient outcome and trying to put some real data together. So each MC will be looking at the use of TXA.
And maybe we can get some of those case studies on the EMS On Air podcast to talk about each one of those administrations and follow up with the patient outcomes and really talk about how this is affecting our home area.
That would be fantastic. It might be several months till we have enough cases to look at, but absolutely, it would be exciting.
And as always, providers, this is a great opportunity. We always have to make sure we're documenting the side effects and the effects of a medication, both negative and positive. Make sure in your documentation you're putting this information down so we can determine whether this is a good drug for us to be using in the field, and hopefully maybe some other MCAs and maybe some other areas across the country will see this and add this if it's appropriate to do so.
That is all for the show today, everyone. Thank you for listening, and thank you to Dr. McGraw, Luke, and John for coming on the show. Again, see the Southeast Michigan Medication Exchange and Replacement Procedure, the shock protocol, and in the medication section under Tranexamic Acid for additional details. You can download these protocols at ocmca.org, or you can just download the OCMCA EMS Protocols app, which you can get for free at the Google Play or the Apple Store. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Check out our website, emsonair.com. Follow us on Instagram at emsonair. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.